Welcome to the Documenting Ambulance Transports Field Operations Specific Compliance Training, Presumptive Criteria, Service Levels, Non-Immediate Responses. By the end of this training, you will be able to understand Medicare's criteria for medical necessity, list Medicare's presumptive criteria, identify the different service levels, understand Medicare's criteria for each service level, and define immediate versus non-immediate response. Medicare and other insurers will only reimburse for ambulance transportation when the patient has a medical condition that makes the use of an ambulance medically necessary. For ambulance transportation to be considered medically necessary, the patient's condition must be such that any other method of transportation would be contraindicated. Therefore, the first step to determining medical necessity is to ask this question: why is an ambulance transport medically necessary for this patient? Or could the patient have been transported safely by any other means? It is important to note that if a patient could travel safely by other means, even if those methods of transportation are not readily available, Medicare will not cover the ambulance transport. For example, Ms. Smith lives in a very rural area of Tennessee. Ms. Smith needs dialysis twice a week, but can ambulate and could sit in a wheelchair in a moving vehicle. She has no regular medical conditions that require monitoring. There are no wheelchair services or even taxicabs available in the area, and Ms. Smith does not drive. Because ambulance is the only method of transportation available to transport Ms. Smith to her dialysis appointment, her physician has requested ambulance transportation for her. According to Medicare's criteria, these transports will not be covered. This is because Ms. Smith could be safely transported by other means if they were available. This is a circumstance in which Ms. Smith will be financially responsible for the transport, and an example of where a voluntary ABN may be used. You will learn more about the voluntary ABN later in this course. To help answer the question why an ambulance transport is medically necessary, or whether the patient could have been transported safely by other means, refer to the list of presumptive criteria provided by the Centers for Medicare and Medicaid Services, CMS. If any of the following criteria has been met and is properly documented, the Medicare carrier is to presume that the transport was medically necessary. Medical necessity generally has been met if the patient was transported in an emergency situation, for example, as a result of an accident, injury, or acute illness, needed to be restrained to prevent injury to the beneficiary or others, was unconscious or in shock, required oxygen or other emergency treatment during transport to the nearest appropriate facility, exhibits signs and symptoms of acute respiratory distress or cardiac distress, such as shortness of breath or chest pain, had to remain immobile because of a fracture that had not been set or the possibility of a fracture, exhibits signs and symptoms that indicate the possibility of acute stroke, was experiencing severe hemorrhage, was bed confined at the time of the transport, could be moved only by stretcher. If any of the presumptive criteria apply to your patient encounter, you must document thoroughly and clearly the conditions and circumstances which support the presumptive criteria and medical necessity according to Medicare's guidelines. Properly documenting medical necessity when the patient truly fits the criteria is an extension of patient care. In other words, it helps your patient. How? Medicare will pay for the transport when it is appropriate to do so based on your complete and accurate documentation. If not properly documented, the patient, him or herself, may be responsible for the bill. Documentation should always be factual and accurate to the patient's condition and the physical limitations that result from those conditions. Rural Metro employees are prohibited from documenting patient conditions that did not exist or services that were not provided. Remember, for ambulance transportation to be considered medically necessary, the patient's condition must be such that any other method of transportation would be contraindicated, or in other words, put the patient's safety at risk. The first step to determining medical necessity is to ask the question, why is an ambulance transport medically necessary for this patient, or could the patient have been transported safely by any other means? The second step in determining medical necessity or reasonableness is to ask why the patient is being transported by ambulance, or in other words, where is the patient being taken? The Medicare carrier is to presume that the transport was medically necessary if the patient condition meets any of the presumptive criteria, but documentation must clearly support the condition and limitations that support the presumptive criteria. Under the Ambulance Fee Schedule, AFS, implemented by CMS, Medicare payments will be based on the level of care required by the patient's condition. Many other payers may also base service levels on these criteria. The service levels are Basic Life Support, BLS, Non-Emergency, Non-Immediate Response. BLS, Emergency, Immediate Response. Advanced Life Support, ALS Level 1, Non-Emergency, Non-Immediate Response. ALS Level 1, Emergency, Immediate Response. ALS Level 2. Paramedic Intercept, or PI. Specialty Care Transport, SCT. Let's look at the criteria and the definitions for each of these service levels. BLS Non-Emergency. Criteria: ground transportation, medically necessary supplies and services, and the provision of BLS ambulance services. Definition: ambulance must be staffed at a minimum by 2 individuals, one of whom is qualified in accordance with state and local laws as an emergency medical technician basic or EMT basic. Operations management. It is important to note that crew member credentials must be current and maintained in accordance with the records retention policy. This means that if Medicare requests confirmation that a crew member was a certified EMT on a date of service from 5 years ago, the certification must be available. This would involve a non-immediate response. BLS emergency. Criteria: the provision of BLS services, as specified previously, in an immediate response to an emergency situation. Definition: emergency response means responding immediately to an emergency situation as described in the ambulance medical conditions list for dispatch and crew from a 911 call or the equivalent in areas without a 911 call system. An immediate response is one in which the ambulance supplier begins as quickly as possible to take the steps necessary to respond to the call. ALS Level 1, Non-Emergency, Non-Immediate Response. Criteria: ground transportation, medically necessary supplies and services, and the provision of ALS ambulance services. Definition: ambulance must be staffed at a minimum by 2 individuals, one of whom is qualified in accordance with state and local laws as a paramedic. The provision of at least 1 ALS intervention. Advanced life support intervention means a procedure that is, in accordance with state and local laws, beyond the scope of practice of an EMT basic. Advanced life support personnel means an individual trained to the level of EMT intermediate or paramedic. EMT intermediate is an individual who is qualified and certified in accordance with state and local laws to perform essential advanced techniques and to administer a limited number of medications. EMT paramedic possesses the qualifications of the EMT intermediate and also, in accordance with state and local laws, has enhanced skills that include being able to administer additional interventions and medications. This would involve a non-immediate response, ALS Level 1, Emergency, Immediate Response. Criteria: provisions of ALS services as specified above in an immediate response to an emergency situation. Additionally, an immediate response to an emergency situation, which the Communication Center determines based on the information provided, requires deploying an ALS staffed ambulance. A paramedic assessment must be performed and documented on the PCR to determine if ALS interventions are required. Definition: the ALS emergency service level criteria are met if an ALS ambulance responds immediately to an emergency situation, as described by the ambulance medical conditions list for dispatch and crew. In addition, to meet the criteria, ALS interventions must be performed or circumstance existed to warrant ALS deployment to an ALS level emergency situation, such as described in the ALS-based condition codes. An ALS assessment was performed and it was determined that no ALS interventions were clinically necessary. An ALS assessment must be supported by all the documentation elements listed in the guide. A checkbox that indicates an ALS assessment was performed by itself does not provide adequate documentation of the assessment. An immediate response to a medical facility to transfer a patient requiring ALS interventions and/or monitoring in a transport to another facility for higher level of care or diagnostic or other emergency services not being provided by the sending facility. These services must be explicitly described in the documentation. An immediate response to a hospital for a transfer to another hospital must clearly document why the patient needed an immediate response and what services are necessary for the patient at the receiving facility that are not available at the sending facility. ALS Level 2. Criteria: transportation by ground ambulance vehicle and the provision of medically necessary supplies and services, including at least 3 separate administrations of one or more medications by IV push, bolus, or by continuous infusion. The IV fluid itself is not considered a medication. Medications administered by oral, intramuscular, intradermal, sublingual, and nebulized routes are not included in the service level. The provision or monitoring at least one of the following ALS procedures: manual defibrillation cardioversion, endotracheal intubation, central venous line, cardiac pacing, chest decompression, surgical airway, intraosseous line. Paramedic intercept, or PI, used only in New York. Criteria: ALS services provided by an entity that does not provide the transport. Definition: under limited circumstances, Medicare payment may be made for these services directly to the entity providing the PI services. The criteria for rural metro to bill Medicare for PI services include a BLS transport agency is prohibited from billing by state law, and the pickup point is in a rural area as defined by CMS. For rural metro, this service level only applies to the state of New York. Specialty care transport, SCT. Criteria: interfacility transportation of a critically injured or ill beneficiary by a ground ambulance vehicle, including medically necessary supplies and services, at a level of service beyond the scope of practice of the EMT paramedic. Definition: SCT is necessary when a beneficiary's condition requires continuous care that must be provided by one or more health professionals in an appropriate specialty area. For example, a paramedic with additional training for SCT transports, nursing, emergency medicine, respiratory care, or cardiovascular care. This is because the patient is at risk or is in single or multi-system or organ failure. This should be part of the documentation. When transport requires specialty care services, documentation on the PCR must include the level of service of the provider, RN, MD, etc., the service level provided by that provider, the reason for the transfer, and the specialty unit the patient was in at the sending facility. For example, telemetry unit, surgical ICU, cardiac care unit, etc. Indicate if the SCT healthcare professional is a rural metro employee or is employed by an institution that rural metro has a contract with to perform SCT transports. Service level example: as ambulance personnel, you may provide care during non-emergency and emergency situations. The criteria for an emergency response are the same regardless of responding to BLS or ALS calls. However, there is a significant difference between the BLS and ALS levels of service. Typically, the BLS level of care is defined by the local area's protocols, while emergency medical technicians, for example EMT or EMT Basic, are limited by providing BLS interventions. Paramedics, for example EMTI or EMTP, are not prohibited from providing BLS interventions. The ALS level of care begins when the patient requires interventions beyond the BLS level of care. These interventions often include the use of EKG equipment and medications, including those used with an IV. Medicare regulations state that just because the local authority mandates the use of ALS-certified personnel does not mean the transport will be paid at the ALS level. Instead, the ambulance transport will be reimbursed based on the medically necessary interventions provided. The following are examples of the different levels of service. BLS emergency. Crew dispatched from 911 to patient who tripped and fell, ground level fall. The responding crew consists of both an EMT basic and an EMT paramedic. The crew is dispatched and on scene within 7 minutes of the call. On scene, the crew finds an 88-year-old female who fell when she tripped when she missed the bottom step of her porch. The patient is alert and aware, has a GCS of 15, but has some swelling in her right ankle. She is assisted to the cot and placed in a position of comfort. Vitals were taken twice during transport, all within normal limits. Upon arrival at the hospital, care turned over to hospital ER staff. This transport would be considered a BLS emergency. The crew responded immediately to a 911 dispatch for a BLS condition. No ALS interventions were provided. The patient may have had a fracture and appropriately received BLS assessment and monitoring during the transport to the hospital. ALS emergency. There are two different circumstances that can result in the transport being billed at the ALS emergency level of service. Let's take a look at the first scenario. Scenario 1. Crew dispatched 911 to a patient with severe nausea and vomiting and possible syncope episode. The responding crew consists of an EMT basic and EMT paramedic. The crew is dispatched and on scene within 7 minutes of the call. On scene, the crew finds an 88-year-old male lying on the floor in the fetal position. The patient is complaining of severe abdominal, 9 out of 10 on the pain scale, has been vomiting every half hour for the last 3 hours. The paramedic documents assessing the patient's abdomen, notes a fever, vitals that indicate high blood pressure, and a rapid pulse. The patient is lifted to the cot via two-man lift. The paramedic administers an EKG to rule out any cardiac abnormalities and starts an IV of normal saline. The patient is taken to the hospital and care is turned over to staff upon arrival. This transport would qualify as an ALS emergency. The crew responded immediately to a 911 dispatch for an ALS condition. ALS interventions were medically necessary and were provided by ALS skilled personnel. Scenario 2. ALS assessment. Crew is dispatched 911 to a patient complaining of dizziness. The crew responding consists of an EMT basic and EMT paramedic. The crew is dispatched and on scene within 9 minutes of the call. On scene, the crew finds a 78-year-old female. On scene, the EMT paramedic documents taking vital signs and determines the EMT basic can monitor the patient during transport to the hospital. The EMT basic takes the patient's vitals twice during transport. Upon arrival, care is transferred to the hospital staff. This transport qualifies for use of the ALS assessment and therefore is an ALS emergency transport. At the time of dispatch, the patient's condition warranted an ALS crew response. The EMT paramedic documented assessing the patient and determined the EMT basic could monitor the patient en route. Immediate response. As you saw in the service level definitions, emergency response means responding immediately at the BLS or ALS-1 level of service to an emergency situation from a 911 call, or the equivalent in areas without a 911 call system. An immediate response is one in which the ambulance supplier begins as quickly as possible to take the steps necessary to respond to the call. These are the criteria for an immediate response to be considered an emergency by Medicare. When dispatched by the local 911 or equivalent, the description of the patient's condition indicates that an immediate response is required. In other words, it must be an emergency situation resulting in an emergency dispatch condition code. Hospital-to-hospital calls require additional evaluation to determine that an emergency response is warranted. This is because hospital-to-hospital emergencies should be infrequent. This information must be documented. All dispatch information as received, including medical condition that generated the request for ambulance response. The type of response, immediate or non-immediate. Reason for any delay in arrival or extended response times when applicable. Dispatchers screening hospital-to-hospital transports should be diligent in determining if, in fact, the interfacility transport requires an immediate response to an active emergency situation, or if the patient is stable and being transported for care not available at the sending facility. Dispatch personnel and/or the ambulance crew should document the specific care or services not available at the sending facility. And Medicare does not cover transports for patient or physician preference. The term non-emergency. When you document the mode in which you respond to and transport a patient, for example, Code 2, without warning devices, Code 3, or with warning devices, you must be careful to avoid the use of the word non-emergency. This is important so that the transport mode does not contradict or become confused with the service level. If you transport without lights and siren, you may describe the transport mode as normal traffic or priority 2 or no warning devices, etc. However, you should not describe it as non-emergency. The best way to describe your response type is immediate or non-immediate. The use of warning devices is an operational issue, and the use of these devices does not alone prove or disprove the emergency response. The determination of the emergency service level is based on whether the response was immediate to an emergency situation. In summary, under the AFS, Medicare payments will be based on the level of care required by the patient's condition. Many other payers may also base service levels on these criteria. The service levels are BLS, non-emergency, BLS emergency, ALS1, non-emergency, non-immediate response, ALS1 emergency, immediate response, ALS2, PI, paramedic intercept. For rural metro, this service level applies only to the state of New York. SET, specialty care transport. For Medicare, emergency response means responding immediately at the BLS or ALS1 level of service to an emergency situation from a 911 call, or the equivalent in areas without a 911 call system. This information must be documented. All dispatch information as received, including medical condition of the patient. The type of response, immediate or non-immediate. When you document the transport mode, be careful to avoid the words emergency and non-emergency so that the transport mode does not contradict or become confused with the service level. Dispatch personnel should document the patient's condition as described at the time of dispatch, and this information should be documented on the PCR. Hospital-to-hospital or interfacility transports should receive additional screening during dispatch to determine if the patient's condition is truly an emergency, requiring immediate care at the receiving facility, or a stable patient needing to be transported for a higher level of care. The actual service level or care not available at the sending facility should be documented on the PCR for all hospital-to-hospital interfacility transports. Congratulations! You have completed specific compliance training, presumptive criteria, service levels, non-immediate responses. Medicare reimbursement is made according to the medically necessary services actually furnished. That is, payment is based on the level of service furnished, provided they were medically necessary, not simply on the vehicle used or the level of certification of the crew on board. Even if a local government mandates, or in other words, requires an ALS response for all calls, payment is made only for the level of service furnished, and then only when the service is medically necessary. Click a button to view each denial modifiers. Click Memorized when